Hi, everyone, and welcome to another episode of Dr. Gilbert Hosts. Today, as you know, we'll be discussing a topic that affects a huge percentage of people with Parkinson's, and that is women and Parkinson's. So while Parkinson's disease affects men and women with many similarities, there are manifestations, progression, treatment responses, healthcare access, psychosocial factors that can be different. So we're going to be hearing from our expert, Dr. Jill Farmer. We also have the privilege of hearing from a woman with Parkinson's, Jeannie Veith, who will be sharing with us her perspective on being a woman with Parkinson's. So we're going to start off with a short introduction to the topic by Dr. Farmer, and I will formally introduce Dr. Farmer to you. Dr. Jill Farmer completed medical school at UMDNJ School of Osteopathic Medicine and her residency in neurology and fellowship in movement disorders at Georgetown University in Washington, D.C. She's currently an assistant professor of neurology at the Drexel College of Medicine and owner and founder of Borough Neurology in Hopewell, New Jersey. Her clinical interests include Parkinson's disease medical and surgical management, botulinum toxin injections for dystonia and spasticity, and functional movement disorders. Her research interests include telemedicine, the emotional and environmental impacts on neurodegenerative disease, continuous infusion therapies for Parkinson's, and utility of wearable devices in managing motor symptoms of Parkinson's. For the past 4 years, Dr. Farmer has been the co-administrator of the Women Neurologist Group, and she helped grow that to over 4,000 members, bringing together an international group of women neurologists from residency through retirement. So very excited to have Dr. Farmer here. Welcome, Dr. Farmer.
Thank you so much for having me. I am really honored to be a part of this broadcast and presenting this topic. As we mentioned, we are going to be discussing Parkinson's and women. And what I would really like to focus on is how women are a unique patient population within Parkinson's disease. And it is something that we recognize well within the community, but has unfortunately been under-researched and has not necessarily made strides in making treatment paradigms and strategies specific to women. But we're looking to change that, and it is changing. So this is a schematic from PubMed, which is the clearinghouse through the National Institutes of Health that house all of the literature, peer-reviewed literature that we can access. And if you type in women and Parkinson's, just brief and general, you see that since 1947, there was practically no data, no research that was being conducted. And then it started to grow almost exponentially. And in 2025, there is a large amount of research that is being conducted. The problem is the type of research is a little bit small. Study sizes are small. It's case reports, it's review articles, things like that. So there isn't necessarily a wealth of investigator-initiated, prospective studies, case-controlled studies, randomized control trials, things like that. But if this shows anything else, it does show that it is something that is becoming more and more researched and more recognized as an active area of research, because, as mentioned, this affects about half the people we treat with Parkinson's disease. Obviously, when looking at Parkinson's in women, the big question is, gender and sex differences, particularly sex hormone differences, particularly estrogen. And I wish I could tell you that there is a standardized, well-resourced guideline about estrogen and Parkinson's disease, but there is not. A lot of the data we have is conflicting and contradictory. But one of the things that we do know, and this is estrogen outside of Parkinson's itself, is that postmenopausal supplemental estrogen for women without a history of prior cancer, breast cancer, uterine cancer, ovarian cancer, things like that, is safe and well tolerated. And we do know outside of Parkinson's that postmenopausal estrogen supplement can help with some non-motor symptoms that we see commonly in Parkinson's disease, but also see commonly with just general aging. So mood, depression, anxiety, sleep, cognition. So even though we don't necessarily have the specifics about how supplemental estrogen helps with Parkinson's symptoms specifically, if we borrow from research and literature in other areas of gynecology and things like that, we do know that there can be a role, and a safe role at that, for the utility of estrogen in postmenopausal women with Parkinson's disease, particularly those that are having concerns and impacts of non-motor symptoms in Parkinson's disease. One of the reasons why estrogen is looked at and considered to play such a big role is it has an impact on the brain. Nothing happens in isolation in medicine. And the more that we learn, the more questions we get, but we also try to find our footing with different and novel approaches to managing Parkinson's disease. We know dopamine is the mainstay of treatment, and the loss of dopamine is the main pathology. But we also know through research and history and clinical experience that it is not just dopamine. And now we have medications that work on things outside the dopaminergic spectrum, that work on adenosine, that work on acetylcholine, that work on different chemicals in the brain, because, again, nothing happens in isolation. What we have found through research in how estrogen can play a role in Parkinson's disease is that it plays a role in oxidative stress, and that it also shows that patients that have animal studies that have been conducted in mice have shown that there is a role of estrogen in oxidative stress, particularly in the dopaminergic pathways. And it may actually be protective, which is why people have often heard that there is a lower incidence and prevalence of Parkinson's in premenopausal women, but that once women hit menopause, that incidence and prevalence sort of equalizes between men and women. There's questions that arise, patients who are on birth control or patients who are on hormone supplements prior, can that have a protective benefit, a neuroprotective benefit? And again, this is where the research is unfortunately conflicting. Some show some benefit, some show no benefit, some shows that it might actually increase risk. So that is why there has been such a confusion and a lack of consensus and guidelines in how to manage this with women. As far as pathology goes, the other thing that we know, though, is that non-motor symptoms in women with Parkinson's and the biopsychosocial aspect of the disease are very different compared to male patients. And what we do know is that as patients have changes hormonally over the course of their lifetime, things that happen to women perimenopausally and postmenopausally that have nothing to do with Parkinson's per se definitely have an impact on that biopsychosocial aspect. So oftentimes women will present with increased depression, concerns about self-worth, concerns about being able to fulfill caregiver roles. And we know that while estrogen plays a role because these are symptoms that may occur even if patients don't have Parkinson's disease, we know that because someone does have Parkinson's disease, we have to pay extra attention to addressing these concerns at patients' visits. And it's definitely not just the motor symptoms that are things that we need to be aware of to manage. So I know we want to get into questions and answers so that what we spend the majority of the time getting to your specific concerns so you can feel that this is time well spent. So I wanted to end on a positive note. And I just like this schematic of women lifting up other women. And that is what we're doing through educational materials and programs such as this, by raising awareness, by having women-specific support groups, by feeling empowered to speak to your doctors about the unique concerns that you have, so that you feel that you have a voice to be able to have your symptoms managed and addressed. This is all going to lead to the ability to have a much more robust approach to tackling the concerns of women with Parkinson's disease. And so I think now we'll have an introduction of our other speaker today to share her stories.
Great. Thank you so much, Dr. Farmer. That was extremely helpful. I think we're having a little audio issue. I hope it's not me, but hopefully we'll sort it out in a minute. Hopefully everyone can hear. It's now my pleasure to introduce our second guest, who is Jeannie Veith, who is a person with Parkinson's. Jeannie has traveled extensively, speaks 3 languages fluently, is adept with computers, has been retired from her 4th career for the past 7 months. She was a radio DJ, a presenter in several jobs. She sang in local and international choirs. So an extremely versatile and interesting person. And at age 74 is finding exercise, a daily health journal, and support groups to be integral to her continued health. Jeannie was diagnosed with Parkinson's just after her 70th birthday, and I am honored to have her here to help us answer your questions. So I invite both Dr. Farmer and Jeannie to join me for the Q&A portion of our program. So let's start off. We have a bunch of questions that have come in as Dr. Farmer was talking. And so we have a great question from Kay Freeman. Have there been, and I think this question is directed to Dr. Farmer, has there been any research on Parkinson's among trans women? I'm curious about the role of hormone replacement therapy with this population.
Excellent question. And a lot of what I will speak about today comes from an excellent article that is available called The Unmet Needs of Women with Parkinson's Disease. It was published in the Movement Disorder Journal. Dr. Indu Subramanian is an expert on this topic as well. And that article does speak about trans and LGBTQ populations with Parkinson's disease. And the lackluster answer is there is not much. It was recognized as an unmet need because we do not have the patient population studies that are needed to really make any particular guideline recommendations. The hormone replacement studies that we do have really focus on people who have had surgical interventions in the past that require them to be on hormone replacement therapy for a surgical menopause or things like that. And even those numbers are incredibly small. So it is, again, recognized as an area of unmet need. The small data that we do have on it is conflicting. So that some people with hormone replacement therapy in the perimenal and premenopausal period and exposure, some have said that it is a risk factor for developing Parkinson's. Some have said that it could potentially be helpful, and others have said it's made no difference.
Okay, well, a lot more that needs to be known and to figure out in the future. So Jeannie, I would love to ask you this question. So there is this general sense in the Parkinson's world that women who present to their doctors with symptoms may have a delay in diagnosis, that they aren't necessarily diagnosed as quickly as men. What was your experience? What was your diagnosis experience as a woman?
Well, I think that my diagnosis was about 6 years after the first symptoms had appeared. No one ever even brought up the topic of Parkinson's disease when I was reporting the symptoms that I was having. And it wasn't until I think about 2 years into trying to evaluate the pain that I was having on my left side, and almost exclusively on my left side, that a neurologist that I saw suggested that I see a movement disorder specialist because he suspected that that's what it could be after examining multiple MRIs and everything and finding that my spine was in perfect condition, or almost perfect for my age. So I think that it's definitely an issue for women, but I think it's not only with Parkinson's disease, it's with a lot of different things for women, heart disease and a lot of other things. And I think in response to what Dr. Farmer was talking about was that the no questionnaire in my Parkinson's journey has ever asked about hormone replacement or when I went through menopause or anything of that nature. So it's not even being collected as a part of the statistics.
That's an excellent point. So I think more focused studies have to really bring out some of this detail that we're just not understanding. It's such a huge difference between men and women, and it's just not understood. So we had actually a few questions about estrogen come in, and one woman asks, "I'm 72. Is that too late to be taking estrogen?" Dr. Farm, you mentioned that estrogen may actually help ameliorate some of the non-motor symptoms. Can you start when you're 72? How does that work?
Is honestly where we defer to our OB colleagues and our GYN colleagues, just to make sure that there are no underlying risk factors that would not, which would prevent someone from starting hormone replacement therapy. But more and more data is coming out, and there's actually a whole subset and subspecialty within obstetrics and gynecology now for menopause. And there are menopause specialists because it's recognized as such a unique time in a woman's life that definitely needs to have more focused care and attention paid to it. And within those communities, there are lots of advocates stating that there is no reason not to be on some form of hormone replacement therapy because it can help with a huge amount of symptoms that women feel, from vaginal dryness to decreased libido to the non-motor things that we see with cognition and sleep and temperature regulation and all of these things. So if you are experiencing symptoms that may have an underlying basis, not just in Parkinson's, but also due to lack of estrogen, then the conversation should absolutely be discussed. Now, where I anticipate patients are going to run into problems is an OB-GYN, and rightfully so, isn't necessarily going to say, well, I think that we should treat this because it could help your Parkinson's disease. So we have to sort of use our best clinical judgment and kind of fall into the art of medicine a little bit, where if you get the go-ahead from your OB-GYN from a perspective of, could something that I'm experiencing be related to estrogen deficiency, and is there any risk with me trying estrogen? They may say, no, there really isn't, but I don't feel comfortable for prescribing it because these might also be related to Parkinson's. That's where you come to your movement specialist and your neurologist, depending on how comfortable they feel, and say, I've already spoken to my OB-GYN. They think that some of these symptoms may be helped. They were unsure how it relates to Parkinson's. And then we can say, well, we don't know specifically how it relates to Parkinson's, but we do know it can help with these symptoms. If you are comfortable with that, then I don't see any harm in giving it a try.
Okay, great. We have a couple more questions just to kind of flesh out the topic of estrogen and Parkinson's. So a couple more questions, and then we'll move on to another topic. One person asks specifically about hormone replacement therapy and cognition. And I know a lot of people are very interested in that connection. Is anything specific that we know about hormone replacement therapy and cognition?
Yes. So that is the one study that was pulled out in the 3 or 4 different references that I looked at specifically for women in Parkinson's disease and the use of estrogen therapy. They all quoted this same one, where it was a short study, only 8 weeks long, to show that it was safe and effective. But the thing that it helped with most is cognition and make sure I'm reading it right, greater functional independence. So yes, if that is the key concern, then more so than some of the other non-motor symptoms or other symptoms that we can discuss, there is data to show that it does help with cognition outside of Parkinson's, but it wouldn't be the first time we borrow from symptoms that are also seen in Parkinson's using data when it was studied in populations outside of Parkinson's.
Fascinating. That's there's kind of a dearth of ways to address cognition and this sort of a new approach. So that's really fascinating. Let me ask Jeannie a question. So another angle to this is that women perhaps tend to be a little more maybe gun shy about treatments, about pursuing kind of more extensive treatments for PD as they advance. And one thing you hear about in the Parkinson's world is that perhaps women don't get deep brain stimulation as much as men. And I'd like both of you to give your perspective on this. Do you think that's a women issue? Do you think that's something that needs to be addressed specifically in terms of women? How would you approach sort of women's hearing information from their doctor, synthesizing it, and applying it to themselves? Jeannie, do you want to give your opinion on that?
Well, actually, the first person that I met who had DBS happened to be a doctor from San Antonio, Texas. And when I met her, I thought probably that her husband was the person with Parkinson's disease, not because of any symptoms, but because that was just my assumption. And she had DBS 3 years previously. You would never know that she was a person with Parkinson's disease. She was able to move so effortlessly and cognitively just right on tack. So I was very pleased to meet her and to find that she had a wonderful experience. I have not personally met very many people with DBS, but most of them have been male. And so far, even when I asked about being evaluated, I was told that my symptoms aren't far enough along, that I'm not in that window, quote, of opportunity for the DBS as yet. But I'm hoping that with exercise and just staying on top of the topic, that I'll be able to utilize that option if and when it should come to that.
Fantastic. Dr. Farmer, any comments on your experience with women versus men and their approaches to their treatment?
Sure. So specifically as it relates to DBS, there is literature to just prevalence literature, utilization, I should say, literature to show that women underutilize DBS. As a whole, DBS is underutilized because traditionally it had been viewed as a treatment of last resort, but through studies like the early STIM studies and everything else that we are understanding, as with everything in Parkinson's, the sooner you intervene, the better. So looking to do DBS earlier is actually the way that the tide is shifting for management. With that said, it still hasn't necessarily shown that there's been an increase in women who are getting DBS. And some of the factors that they feel for this is numerous in the spectrum of all things that go into deciding whether or not to have surgery. For women, as you just heard, sometimes the severity of their symptoms can be viewed as not as severe as some of the male counterparts that are coming in who are complaining about their symptoms more. Women tend to downplay. Women tend to say, no, everything's all right, because they'll just deal with it and figure out how to make stuff work. So when someone is hearing that and the suggestion is for surgery, they might say, okay, well, then your symptoms are not necessarily at the point where we really need to discuss or consider this. Some of it is the process of the DBS themselves. When the patients hear that they need to shave their head, that impacts women more than it does men. And while some people might not view that as a really big hurdle, there are other people that find that quite off-putting and don't necessarily like the idea of having to wear a wig or wait for their hair to grow back, things like that. There's also the concern as caregivers. So women are patients and caregivers for their partners. And there's data to suggest that As far as caregiver roles go, more women end up in nursing facilities and assisted living facilities than men do because of the imbalance in the comfort of being in a caregiver role. So if women have surgery and they're going to have a recovery period, that plays on their mind as to whether or not they can fulfill that caregiver role for their partner if their partner needs it. So there is a lot more that goes into the decision for a woman to consider DBS than a male patient to consider DBS. And I think when we're approaching it, we have to be aware of those concerns and not just the usual, what symptom are we looking to manage and treat? This is the time course of the procedure and you meet the requirements or are a good candidate. The other biopsychosocial aspects definitely need to be addressed and discussed. And some docs might need a little bit of a primer on the key points to bring up when they're having that conversation with different patient populations.
Fascinating. Great, thank you. We have a great question from Audrey Rinker, who is interested in young onset Parkinson's in women and early signs of Parkinson's. So maybe Dr. Farmer, you start us off and talk about young onset Parkinson's in women. And then maybe Jeannie, talk about your early symptoms and what was kind of the first things. You talked about it a little bit, but maybe flesh out what exactly you were experiencing all those years before you were diagnosed. So thank you.
Sure. So women tend to have more tremor predominant type Parkinson's than the other classical presentations. So just as a brief background, Parkinson's is on a spectrum, and there are a ton of ways that Parkinson's can present. But if we're going to try to keep it simple, the three classic presentations of classic Parkinson's disease are tremor predominant, which is just what it sounds like. Tremor is the most obvious feature. Postural instability gait predominant, where there's very little tremor or no tremor at all, but balance and gait are the predominant features. And akinetic rigid, which again, there's very little tremor, but stiffness, rigidity, bradykinesia are the predominant features. Of those three presentations, from the data that has been collected, it seems that women tend to present with tremor predominant Parkinson's most frequently. The early presenting symptom prior to that tremor really manifesting and making it a little bit easier to diagnose tend to be the non-motor symptoms for women, which, as I mentioned them, you can see how these will not automatically get linked with a potential prodromal phase of Parkinson's disease. So things like constipation, depression and anxiety, irritability, or in the sense of, feeling uncomfortable in their own skin, not being able to multitask, feeling like they are, not keeping up with the bar that they set for themselves. So if a 50-year-old woman is coming in to discuss these complaints or concerns, it's not necessarily going to steer someone to be thinking about Parkinson's disease. They might be thinking, oh, it's anxiety, or, oh, it could be, hormonal and perimenopausal. And it's not that these thoughts are incorrect. It just delays the diagnosis. So if that's the initial thought, and that's fine, that shouldn't be the same thought a year down the road if symptoms aren't changing with the interventions that people are suggesting they do. Then you start to think a little bit further down your differential of what can be potentially causing these concerns. And as a movement specialist, we know that those are classic triads of things that we see for Parkinson's disease. But that is not necessarily well known in the general medical community.
Great, thank you. So Jeannie, could you elaborate a little on your very early symptoms and what you thought was going on?
Sure. Well, I think the first one that I recognized was constipation, and that was almost 6 years before diagnosis. And I did bring that up to primary care practitioners over and over again, not every visit, but at least once a year I did. And then another was frozen shoulder. I had frozen shoulder 3 times over the span of 2 years. And in retrospect, my physical therapist did tell me after my diagnosis that she had thought that there was a relationship there, but she never mentioned it because she didn't want to bring up a diagnosis when the doctor hadn't. Then stiffness and rigidity with pain on the left side, the leg on the left side, which is what led me to neurology, to MRIs. That was 2 years before diagnosis. And then dreaming out loud, not with movement, but literally screaming at the top of my lungs in a hotel room, which surprisingly didn't get any calls to management from the neighboring rooms. And at the very last was tremor on the same side that I had the stiffness and the rigidity. So, and that is what I think eventually led the neurologist that I saw about the leg pain to suggest that I go to a movement disorder specialist. So it took almost 6 years.
Wow. It's funny when hindsight is 2020, when you hear those symptoms, it's sort of like checking every box of that premotor Parkinson's that movement disorder specialists look at. But we're always looking at the person who has Parkinson's and we look backwards. But we have to start going from forwards and forward. You're figuring out.
And I think that maybe primary care doctors need to be a little more educated on this and to start looking at people at least in their 50s to see where some of these symptoms might come in, especially with the originating symptoms. So many people begin with constipation. And when you're looking at this, and frozen shoulder, who knew? I certainly didn't know that that was a common symptom, but it is.
Yeah. Fascinating. Thank you. We have a great question from Kathleen. So as our audience may know, that there is a new drug on the market for Parkinson's called Crexont. It's a extended release carbidopa levodopa. And the question really, I want to broaden it a little bit. The question is, what about side effects to medications and a new medication where we're not really fully understood what the side effects will be? Do we see differences in men and women in side effects of medications? Maybe Dr. Farmer start, and then Jeannie, you can continue.
So the one main difference that we see is the onset of dyskinesia. And again, that's not well understood as to why. The leading theory has to do with body weight. Even though we don't dose our medications based on body weight or change for any kind of clearance for the most part. There is some data to suggest that dopamine, once converted from levodopa, can have higher plasma levels or bioavailability in women. And because of that, they may go on to develop dyskinesias more quickly. So that's not to say that you ration carbidopa levodopa in women with symptoms that warrant using it, but it does mean that you can have the conversation with them that if motor symptoms are not quite as pronounced, if they're on the younger end of the spectrum, do they want to start with carbidopa levodopa? Do they want to try alternatives to carbidopa levodopa to see if they help their motor symptoms without necessarily building up to that concern for the development of dyskinesia? But other than dyskinesia, there really is not much difference between concern for one particular side effect over another between men and women.
Thank you so much. Just to flesh out Kathleen's question a little bit more, she noticed mood and agitation as side effects. And I think what you're saying is that there isn't, the major difference between men and women would be dyskinesias, and other side effects would be similar between men and women.
Mm-hmm.
Thank you. So Jeannie, any comments on side effects that you've had from medications and, your responses to the treatments that have been offered you?
The medications that I actually have taken and continued with, I have not noticed side effects from. I've been very lucky in that aspect.
Fantastic. Thank you so much. We have a great question from Karen Patterson, who wants us to discuss a little bit about diet. So I want to broaden the question a little bit. Karen asks, please talk about the importance of diet regarding how our medication works and doesn't work, and does this affect women? Maybe let's broaden a little bit more about women's association with diet, and whether there's a difference between men and women, and whether they appreciate diet as a part of their treatment plan, and maybe how women relate to their food a little differently than men, or not. Maybe Jeannie, you want to take this, and then Dr. Farmer?
Well, I have to also backtrack. One of the medications that I am on, pramipexole at nighttime, has got a side effect of weight gain. And I have noticed that, and I have had to go on a more restrictive and a Mediterranean diet to really help with that aspect of it. I don't want to be 20 pounds heavier than I've ever been in my life. So I'm really working to keep that under control. And that happened to me even though I was exercising a full 4 hours a week with a very aerobic exercises. And I just wasn't prepared for that. And as soon as I found out that one of my medications had that as a possible side effect, I got on top of it. So those things can happen, but yeah, diet is important in every aspect of our lives. And I think we have to be very cognizant of that, along with the interactions which might be happening with the absorption of carbidopa, levodopa in our own bodies, and how that might differ from person to person, and manage our diets accordingly.
Fantastic. Dr. Farmer, anything to add about diet?
Yeah. So as mentioned, it's not necessarily something that is shown to be different between men and women, but you don't even have to be in medicine to know that men and women have very different views on weight and diet, and how women, it is well documented that women's relationship with food is far more complicated than men's. My own experience, my husband went on a fast. He dropped 25 pounds. I went on that same fast and I dropped 12. I mean, it wasn't bad. I was happy with my 12, but it was nowhere near as robust as it was for him. So that, we do know, has a relationship with hormones and where we are in the premenopausal, perimenopausal, postmenopausal stage. So while the side effect of weight gain may be the same, potentially the same for both men and women, we know that older women are going to have a harder time losing that weight should they get the side effect of weight gain. So it's something that should be discussed. But as Jeannie also mentioned, it's not necessarily something that would prevent us from using the medication, because the medications are good, but it does require some behavioral changes and modifications on the patient's end to address it, which not everybody understandably likes. They don't want to have to take a medicine and then have to change something about their diet, their exercise routine, all of that, because the medicine is demanding they do it, and it's not necessarily part of something that they would do naturally. There's obviously no easy fix, but the relationship between weight gain and food absorption is a little bit different for men and women, also because of the concerns for constipation. And we were talking about constipation being an issue that's across the board in Parkinson's disease, but women have a higher incidence of GI dysmotility outside of the world of Parkinson's. And we know that that can then affect absorption of meds. So having this conversation about good regimen, staying hydrated, increasing fiber, while it's a discussion I have with both men and women in my practice, it is definitely something that may need to be a little bit more rigorously discussed or enforced, particularly if women are having difficulty with on-off phenomena, regularity, and absorption of medications.
Great. Thank you so much. Just want to move on to another topic. We're kind of nearing the end of our time, so I want to get a couple more topics in. And I want to talk about clinical trials. So in general, is in your experience, Dr. Farmer, do women participate more or less in clinical trials than men? And is there a way to specifically encourage women to participate in trials that may be specific about women in Parkinson's?
Sure.
What's your experience with that?
So yes, it has been noted over the literature that there is less of a population of women that participate than men, and that is multifactorial. So again, with the incidence and prevalence of Parkinson's, men tend to present earlier, younger, and have a higher prevalence in those premenopausal windows for a woman, I should say, not for men, but you know what I mean, that age range. And because of that, if they're pulling in early or naive patients or recently diagnosed patients, there may just be a larger pool of men to pull from to do those studies. At the postmenopausal phase, when incidence has been shown to equalize between the two, a lot of those same biopsychosocial issues that went into wondering whether or not to get DBS also go into the role of participating in studies. Some women rely on others for transportation, or their husband does the driving or things like that. And so getting back and forth for repeated study visits can be difficult. Some, again, are caretakers for aging parents or their spouse, and they don't feel like they have the time to devote to participating in a clinical trial. Some may really just want to address their symptoms at hand because they need to keep going and get, symptomatic relief so that they can participate in the responsibilities that they have on a daily basis, and don't want to risk not doing that for the sake of a clinical trial drug that may or may not help them. And these are not necessarily things that are unique to women, but they definitely have been shown to be barriers for women participating in studies. And that, I think, is something we need to address for recruitment and figure out different and novel ways to be able to make this fit into lifestyles a lot more easily. And I think that would help across the board, both men and women agreeing to participate in studies.
Fantastic. Jeannie, anything to add about clinical trials and women?
Well, I absolutely agree with the transportation part of it. I have participated in a few clinical trials. When they're available via Zoom or mail or email, then it's way easier to do. I have recently traveled to Seattle using public transportation to participate in a couple of trials. And it was more difficult to plan doing that. Plus, I did not feel comfortable doing it without someone going with me. So I convinced someone else to go with me who could participate in them as well. That worked out really well. But if it's further afield, further than that hour away, that I think that it would be really, really difficult to participate in them.
Yeah, you definitely highlight some of the key barriers that people try to work through to get more participation. So thank you for that. I want to move on to another topic, which is support networks. So Jeannie, what is your support network for Parkinson's disease? Are there a lot of women in your support network? Is that an important feature of being one of your support system partners, or not?
Well, I think it is. And I have found actually in the actual support network, the first group that I ever met with was the press group, which was part of APDA. And it's an introductory 8-week class that meets once a week. And we did that via Zoom because it was during the pandemic. And that group of ours continues to meet 3.5 years later. So that's been really, really good. On that note, though, of women, there's only one other woman in the group. And so that makes it really difficult to have a support network as far as it goes with that group. But I have found that in the Rock Steady boxing group that I'm a member of, 50% of us are women. And the hardest workers, I'm going to have to go, the hardest workers are the women. The women really, really work at the physical part of it. And I believe that it's really showing a difference for the women. I've been able to reduce my Parkinson's medications by 1/3 since I really started doing aerobic exercise, to include the Rock Steady boxing. So I think that is a tremendous advantage for me personally. And I feel much stronger. I've been able to do a whole lot more. And our local Parkinson's group, which just started in January because our city didn't have one previously, has taken off. And now we have close to 30 people who are members of the group, of which about 15 attend off and on a regular basis. So I think that socially it's really important. A lot of my support people in the network are not people with Parkinson's, but people who are interested in Parkinson's or who have a nursing or medical background and happen to be friends of mine.
Okay, that sounds very, very useful to you. That's wonderful. So we discussed, a lot of things. We discussed estrogen. We discussed support networks, clinical trials, dyskinesias, motor symptoms. We have a question from Pat Ray, and you did address this a little bit, Dr. Farmer, but maybe we'll just go back to it and discuss it a little more. This person is noticing that there is an increased sensitivity to heat exhaustion, maybe increased sensitivity to heat in general. So is this related to, is this a woman-man thing? I mean, obviously it can be an issue in menopause. How do you dovetail issues that may be Parkinson's related, menopause related? How do you know what's what and how to sort it out?
Through questions. The things that I'll try to tease out at the visit is heat intolerance, like you said, can be kind of all over the board. If heat intolerance is really someone always feels cold, then typically that is more a Parkinson's thing than a menopausal thing. If the heat intolerance is that someone feels like they have the heat of the sun inside of them and it's radiating out, then that's something that's typically more a menopausal thing than, or a hormonal thing, I should say, than a Parkinson's thing. But we do know that heat variability and sensitivity is seen in Parkinson's disease. And one of the other ways that I try to help tease it out is if you find that this is better when you take your Parkinson's meds, then we may be able to say that it's more related to the dopamine deficiency than a hormonal one. If you really can't tell, then it's sort of trial and error to see which it might be. If it involves sweating is also something that we have to see. Is it something that's happening overnight? Is it related to the environment in which you sleep? Or could you be in a very light t-shirt with just a sheet on and you still wake up drenched overnight? That typically tends to be more hormonal related than PD related. But it's also something that you need to bring up to your other doctors just to make sure that there's no other issues going on that can be related to those types of night sweats that can sometimes be seen. So yeah, like it is really trying to tease it out through context, history, and how it responds to dopaminergic medications.
Okay, that actually makes a lot of sense. Thank you for breaking that down for us. We are at the end of our time. So what we're going to do is ask one last question and then ask for your final comments. So our last question, going back a little bit to our estrogen conversation, is there any research regarding dopamine medications and menstrual cycle? So before menopause, is there evidence that medication may be more or less effective during a monthly menopause, menstrual cycle?
Honestly, I don't know. So I'm sorry to leave it with an I don't know answer, but I am not sure if there's been seems to be any change in how effective medications can be during that period.
Okay. Well, thank you so much for that. So I want to give you a chance to leave us with some final thoughts. So we'll start with Jeannie. Any final thoughts you want to leave our audience with?
Well, I think one of the things that I've noticed is in the caregiver population that women are kind of trained to be caregivers. And we have that role whether we are Parkinson's patients or not. People with Parkinson's often are caregivers for their spouses. And for those of us who are people with Parkinson's and female, it's sometimes difficult for our male family members to assume that role of caregiver because they haven't learned how to do that. So part of the difficulty for me is trying to teach that role and to make sure that I have other people in my life who can assume parts of that role, such as my friends who are stepping up to be parts of my care community. So I think that we have to have a little bit wider pool of caregivers in our lives. And sometimes that's difficult for us to originate, to get started with. But it's something that we do have to step into and step up to.
Very wise. Thank you. Dr. Farmer, any last thoughts for our audience?
Sure. So I'm preaching to the choir with everyone who's on this webinar because you are obviously individuals that are interested in seeking out information and learning and advancing care in Parkinson's disease. So I would say plant the seed. If you are seeing a movement specialist or even not a general neurologist, a general practitioner, and they have spoken to you about an interest in research or things like that in the past, say, I'm aware that there's not a lot going on or available, I should say, with research looking at women with Parkinson's disease. Have you ever thought about doing a survey or a study or something, or are you aware of anything that is in the pipeline? Bring it up to advocacy organizations like the APDA, because if there are avenues with which to help proceed with gathering this information, sometimes that's all that's needed. Sometimes it's just planting the seed or seeing that there is a way to get started, and it doesn't have to be a huge trial or something that's overly complicated. It can just be gathering information to write up the start of a larger idea. And if we hear that this is something that our patients want, then it's something that will help us prioritize what we need to pursue.
Thank you so much. So we are at the end of our broadcast, and I want to thank both of you so much for all that really fantastic information. It was really wonderful to hear both your perspectives, and I know I learned a lot, so thank you. And I want to thank everyone who's listening for participating and giving your questions in. And if you know somebody who missed today's program, if you joined late, if you want to watch again, it's going to be available immediately on our YouTube channel, so you can go ahead and do that. And while you're there, of course, don't forget to subscribe. So for additional information and resources, please visit our website, apdaparkinson.org. I want to let you know that our next episode, our next Dr. Gilbert host, will take place on Wednesday, January 8th at 1 p.m. Eastern Standard Time. And we'll be discussing the many forms of carbidopa-levodopa. We'll be talking specifically about the 2 newly approved formulations of carbidopa-levodopa and how they fit in with the more established medication. So that should be a really interesting conversation, and we hope you're there for that. And that's on January 8th. So be sure to stick around for a few final messages. And before I go, again, I want to thank you for joining us and for participating. And we hope to see you again very soon on another APDA program. Have a wonderful afternoon.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.